Hello, everyone. Welcome. We're just going to get started in a few minutes, just letting people join from the waiting room. While we're getting started, if you want, you can introduce yourself in the chat with your name, pronouns, and where you work. That would be great. Okay. Well, if you're just joining, if you could just put your name, pronouns, and where you work in the chat, but we will get started. So thank you all for attending today. Today we will be offering continuing education for registered nurses. I may have said that in the past, it was a false promise, but I promise today it's real. Health One is offering our CEs today, so we wanted to thank them for that. So stick on till the end of the presentation and we will give you that evaluation survey so that you can receive those CEs via email. But I wanted to introduce you today to our two speakers. First, we have Dr. Tracy Vozar. Dr. Vozar received her doctorate from the University of Iowa with a concentration in perinatal psychology. Dr. Vozar continues to work in psychology with a focus on perinatal health as an associate professor of psychology at the University of Denver and is also the director of Perinatal Through 5 and the Caring for You and Baby Clinic. Our second speaker is Dr. Amber Johnson. Amber is CPCQC's new quality improvement coach, which we are extremely excited about. And she's also speaking today. Amber received her doctorate in nursing from Duke University while simultaneously working as a certified nurse midwife at Avista Adventist Hospital in Boulder County. Amber also has experience in quality improvement abroad at Lira University in Uganda. So please help me give a warm welcome to both of our presenters. And I will advance the slides for you as well.
Okay, thanks. I'll tell you if we're on the right slide.
Yeah.
You can go ahead and move forward. So thanks for that introduction. Hi, everybody. I'm Amber Johnson. Happy to be presenting today, helping out with CPCQC's QI work. I'm always available if you guys ever need a contact and need support in the QI world. I wanted to start today with our first slide. I'll give you a quick second to go ahead and read over this. So Karen Kleiman is a licensed social worker, and she's the founder of the Postpartum Stress Center. She initiated the Speak the Secret campaign, and through that campaign, they use comics to acknowledge the challenges of perinatal mental health. I think it's a really powerful campaign that's used on social media, and I wanted to use it to kind of set the tone for today's talk. So today we're going to focus on the maternal mental health portion of the COAIM SUD initiative. We're going to take a look at the very specific validated screening tools that we recommend as part of our process, as well as how to interpret the screening tools and when and how you should act upon the screening results. But before we begin, as a quick side note, I'd love for you, when you get a chance, to comment. We are sort of refining our protocol around screening for ACEs and social determinants of health. So if your hospital is already screening for those things and you have a validated tool that you're using, comment and let us know if you're screening and what screening tools you're using. So next slide. I want to start by kind of setting the stage. Sorry, back one slide, Elena. I want to start by kind of quickly setting the stage for a lot of the information that we are very familiar with, that perinatal mood and anxiety disorders, for which we're going to use the acronym PMADS. They affect 1 in 7 pregnant persons. This makes it the most common complication of pregnancy and childbirth. And the research has shown us that the diagnosis, treatment of depression and anxiety is less frequent in the perinatal population than in the general population. And there's a few contributing factors to this, many of which you guys probably predict. One is the lack of provider training in OB staff. It's a lack of time or time constraint barriers in the clinical setting. And finally, it's low access to mental health care consultations in the event of a positive screening tool. Next slide. So we know that PMADs have both short and long-term effects on the birthing parent and on the child. This includes low rates of feeding, higher risks of preterm birth, impaired maternal-child bonding, and in the longer term, impaired child cognitive and emotional development. Next slide. The manifestations of PMADs occur on a wide spectrum of frequency and severity. And so most commonly, we can see the 50 to 80% of patients who experience baby blues in the first few weeks in the postpartum period, another 11 to 17% who experience persistent depression and anxiety either during the pregnancy or up to a year postpartum. And then the very small but critical percentage of patients who experience acute postpartum psychosis. Next. We know that the early identification of PMADs has been shown to predict better outcomes and to reduce depressive symptoms. It also increases remission and treatment response. The perinatal period of the patient, it presents a really unique opportunity within a healthcare setting that we don't often see with other patient populations. The perinatal schedule, and particularly the prenatal schedule, promotes really frequent contact with healthcare professionals. And this gives us a really unique opportunity with multiple opportunities to screen for and to address PMADs. This includes the intrapartum period in the hospital setting. PMAD screening during pregnancy and postpartum is recommended as a core component of obstetric care by many of the organizations that we use to base our practice upon, including the USPSTF, ACOG, ACNM, APA, among other organizations. In our COAIM SUD protocol, we recommend several validated screening tools as part of the QI protocol. I want to highlight the 4 tools that we use as recommended. The Edinburgh Postnatal Depression Scale is recommended for depression in the perinatal population. The PHQ-9, many people, even in the primary care setting, are familiar with this tool. It's also used in the perinatal population for depression. The anxiety screening tool we highlight are the GAD-7, or the Generalized Anxiety Disorder Screening, and the PASS, or the Perinatal Screening Scale. I want to note that it's recommended that you choose both one screening tool for depression and one screening tool for anxiety. And the reason for this is because perinatal depression and anxiety are highly correlated. I'll turn it over to Dr. Vozar from here.
Thanks so much. I think we're actually maybe one slide behind. Let's keep going. Maybe a couple slides behind. Sorry about that. Hi, everyone. My name is Dr. Tracy Vozar. I have been doing this work since 2000, and so been in this realm for a little while. And I remember when we first rolled out screening using the Edinburgh Postnatal Depression Scale, the EPDS, back in the olden days, right? So screening's come a long way since then, and there's a lot that we've learned. And whereas screening with the EPDS, as well as some of the other screening tools that we're going to discuss with you today, is certainly ahead of where it was when we first started, there's a lot that we can still do to refine and to hear from you all about what's working around screening and what's still a challenge. So one of the things for us to note with this audience is we're very aware that labor and delivery is not the perfect time for screening. I'll point out that there really is no perfect time for screening, as we really should be screening throughout pregnancy and into the postpartum period at multiple time points and intervals. But we know that we're at least having eyes and ears on our women during this time period and our parenting persons. And so it's a useful touch point for screening. We also know that we have the time and the space, more so than during a short visit. I know time is always at a premium, but more so than during a short obstetric or postpartum visit, to check in with our women a little bit longer during this time period. And we're certainly aware that these time constraints can make screening difficult, even on inpatient. So we're going to be brainstorming with you a little bit today. So of course, in screening, we're asking our pregnant and postpartum people to report their most personal information that many might not even share with a close friend or family member. And we're often asking them to do so with little or no prior relationship, sometimes even little or no rapport built up at this point. And that's why one of the things that we are recommending, and that's really changed over years, is to take a more a relational approach to screening. So even in just a minute, talking about why we're screening, why it's important, what's going to happen with their information, and checking in to see if there are any concerns around what happens with these screening tools once they've responded, is really truly important to the entire process. I would argue that it's essential. And knowing that screening tools are not perfect. So I absolutely love the cartoon shared at the beginning, and recognizing that even with the tools that we're going to be talking about with you today, we're not going to address all of the concerns that a woman is likely experiencing during this time period. So when we're finishing up, wrapping up screening with the tools that we're using, asking our patients whether they have other concerns about their well-being that we've not yet addressed or covered using the screening tools is essential. So important. So what might this look like? These are my words. This is how I would go about introducing screening, but by no means is this the only way to do so. And as I talk about with my supervisees, I think it's lovely if we can put these sorts of introductions into your own words so that they come across as more congruent and genuine. But I might introduce screening along the lines of this. Hi, I'm hoping now is a good time to introduce our mental health screening to you. We care about your overall well-being, including your emotional and relational health. We use screening tools that are used across hospitals and clinics to better understand how you and others like you are doing emotionally. Your responses on the questionnaire will be reviewed by me, and they may be shared with your physician. And we as a team will develop a plan for your further care if it's needed or if it's desired by you. Do you have any questions for me or concerns about screening? And would you like to read the questions, or would you like me to read them to you? And that last question is really helpful for those who might actually have some reading limitations, or who might appreciate more of a conversation around their mental health than being handed a paper and pencil tool. We all have different preferences around how we like to answer questions like these. We can move on to the next one. So remembering that screening by itself does not improve perinatal outcomes, but that we really need to screen effectively, create that initial relationship, and then think about what the screen is telling us and whether an additional referral for outside treatment is important. That's how we're going to move to making those warm handoffs and really improving perinatal outcomes for folks. Okay, I'm going to pass it back to Amber, who's going to walk us through some of our screening tools and thoughts around next steps following the screening.
Thanks. Yeah, I want to highlight again that screening itself is not the ultimate goal. A lot of focus of our initiative is just implementing systematic screening, but the aim here is to reduce illness and suffering, not simply to check box that we've screened patients. And to achieve this, your site has to develop a personalized workflow for handling positive screens. And so in the next few slides that we're going to go through, what I'm going to do is address just the general recommendations around positive screenings, with the knowledge that you are going to have to decide at your particular site, whether that's an outpatient or an inpatient setting, what resources are available to you and how you expect your healthcare providers to act upon a positive screen. So what I'm going to do is this chart here that's on the screen is specific to the EDS. It's a chart exactly like this that's for all of the 4 screening tools that we use in the SUD protocol. I'm going to kind of step you through how to interpret this just using the EPDS chart here, but know that there is a similar chart for all of the screening tools. And what we've done here is that we've highlighted for this particular screening tool for the EPDS, any patient that's scoring more than or 10 or more, you're supposed to notify the patient's provider. In this protocol, sort of assuming that the screening healthcare provider is likely a registered nurse, in the interpartum setting. And so certainly providers like nurse midwives and physicians are equally equipped to complete these screening tools. And so when we say notify the patient's provider, sometimes that means you, notifying yourself and flagging for yourself that this patient has a positive screen. For the EPDS, if you interpret the screening tool that the score is from 9 to 11, this indicates that depression is possible. And in that screening range, what the recommendation is watchful waiting, reviewing precautions for perinatal mood and anxiety disorders with both the patient and their family members, and then repeating a screening tool in the outpatient setting at a routine postpartum follow-up visit. For the EPDS score of 12 to 13, this indicates that there's a fairly high possibility of depression. And for this range, the recommendation is to notify a provider or flag it for yourself that this is a positive screen. And then to move forward with diagnostic assessment tools. And this should be either done in partnership with the patient's provider or ideally a mental health care provider, depending on what's available in your setting. The recommendation, in addition to moving to diagnostic assessments, is to have a short-term follow-up scheduled. And depending on the patient's clinical situation, this short-term follow-up would ideally be within 48 hours to 2 weeks. So no more than 2 weeks before this patient is seen by a healthcare provider or a mental health care professional. And then finally, a score of 14 or higher indicates probable depression. And in this range, the recommendation, in addition to notifying the patient's provider and moving forward with a diagnostic assessment tool, ideally in partnership with a mental health care provider, is to have a plan for treatment that's established prior to the patient's discharge from the inpatient. And it can involve medication, it can involve a scheduled follow-up with mental health care provider, it can involve a mental health care consultation in the hospital setting prior to discharge, but it's something that needs to be addressed and have a written plan that's established prior to the patient's discharge. In the teal box on this slide, you'll note that, sorry, I'll go back one. Yeah, okay, we're still on it. On the EPDS one, on the teal box, you'll note that we flagged that item 10 on this assessment tool is an assessment for suicidal thoughts. So an affirmative answer to this question always initiates immediate assessment prior to the patient's discharge. And almost all of these tools that we've recommended have a specific question that addresses suicidal thoughts, and those are flagged in the teal boxes on these slides so that you can implement those into your workflow for how to handle a positive screen. I did want to highlight here on the next slide, Elena, I included the Massachusetts Child Psychiatry Access Program workflow for a positive EPDS screening tool. I'm not going to walk you through this because I just presented a really simplified version of it, but I think this tool is excellent to have on your unit or your practice setting. And so if you have a binder or a folder or a resource your sort of area for SUD, this tool is excellent to have within that protocol. You could put it up on a bulletin board. Again, the EPDS is one of the tools that's most commonly used and most familiar to your staff. And so knowing how to act on that tool, this is an excellent resource for that. So next slide. These next few slides, again, I'm not going to step you through each one of them, but they function exactly like the EPDS one that we just walked through, where they tell you the screening scores that should be highlighted and notified the patient provider, which screening scores necessitate a short-term follow-up, which ones need to be addressed prior to discharge, and then which screening scores actually need immediate attention and possibly emergency services care for suicidal thoughts or behaviors. So we'll jump through the next couple of slides pretty quickly here. We have one for the GASN and finally a similar protocol for the PASS. And now we're back to scripts and I'll turn it back to Dr. Vozar.
Yeah, and I love having those decision tools for screening available and somewhere where you can kind of keep it in your eyesight, whether that's on the wall or in a chart somewhere easily accessible. It just can really help when you're making those moment-to-moment decisions. So let's say you have a positive screen. Either you're concerned about a particular item being quite high, or one of the suicidal ideation items coming back positive, or the overall score, for example. Some ideas for ways to talk with the patient following are certainly to look over the screens and get a sense of what they've been experiencing, and then summarizing and reflecting with them. So thanks for answering those questions. It looks or sounds like you've been experiencing symptoms of, and mentioning some of the symptoms that are popping up that you're seeing through the measure. And then if suicidal ideation is endorsed, talking a little bit about, you've noticed that they're also sometimes having thoughts of maybe harming themselves, and that you want to acknowledge that, and that you appreciate that they've shared that with you. And then moving on to, based on their responses, what you would recommend. And going back and looking at the ideas for next steps of each of those screening tools can help you in thinking about what comes next for the patient. We do get a lot of screens that are either scores of 0. You've probably seen those all the way across the board. What I say with my students is that if you're walking around, you should have a score probably higher than 0 more days than not. And so a score of 0 on any of these measures is concerning and suggests that there's likely some minimization going on. But you can always follow up with a statement such as, it seems you don't have any concerns at this time that are at least being addressed through this screening tool. Do I have that correct? And are there any other concerns that you have that these questions are not addressing? I always think of a woman that I've had the honor of working with, who had severe PTSD following her labor and delivery, and for months into the postpartum. She did not, however, have symptoms of depression. And so the EPDS was missing her severe PTSD diagnosis. And if anyone had asked her, are there other concerns that you're having that feel unusual for you right now? She would have been relieved to talk with someone about what she was experiencing, but she felt like there wasn't the opportunity to share because her experience was not being reflected in the screening tools that were being used. So keeping that option open for folks to share other symptoms or concerns that they might be having is essential, especially since we're not doing thorough assessment with these screening tools. We're really looking at some of the most common mental health concerns that can come up during this time, but there's a wide spectrum of mental health difficulties and stressors, substance use, intimate partner violence, that we may not be addressing with these screening tools. That's really important for us to know as their providers. The last thing that you could choose to share with your patient here following review of the screening tools is, it seems that connecting you with a provider who's trained in working with you on the concerns you're experiencing would be a good idea. Are you comfortable with me providing you with some referral options? And then moving forward from there. So we do have some more targeted screening tools if there has been a positive screen, and or if a client shares with you, a patient shares with you that they're actually experiencing different symptoms. These are available to you and can be found. Some of the additional screening tools that are available are around OCD, PTSD, as I was just mentioning, sleep disorders and difficulties, of course, postpartum psychosis, which is rare, but also is something that we in particular want to be screening for, because it is, although one of the most rare mental health difficulties, one that can be more severe for patient as well as child health and well-being. It's also one that labor and delivery is a particularly useful touch point for screening and for noticing that your client may be experiencing symptoms, as postpartum psychosis tends to occur a little more within the the labor and delivery time frame, around 72 hours following labor and delivery on average. So keeping an eye out for that is useful. And then we were also mentioning, Amber mentioned ACEs and other concerns that we can be hearing from you how you're screening and thinking together about how we might want to screen in the future. One tool that I wanted to bring to your attention, and this will be included in the resources section, you can also find it through the Postpartum Support International website, is the Perinatal Mental Health Discussion Tool. I love this tool. I'm so pleased that PSI has been placing it out there. It gives a brief overview, just as Amber did at the start of today, of why it's important to pay attention to perinatal mental health, and a little bit of psychoeducation, and then talking a little bit about being your own advocate and how the patient can talk with you as their provider about some of the things they might be experiencing. And so there's a variety of symptoms, stressors, and difficulties here that a client or patient could endorse that then you could follow up on and talk more with the patient about. And there's also a list of risk factors that are associated, related with postpartum depression and anxiety. And it can be helpful for us, of course, to know what those risk factors are. And it can be helpful for us to make connections between some of the risk factors that the patient is endorsing and why they may be at a heightened risk for mental health difficulties or concerns, given some of those risk factors. Again, just to provide some more context and some more psychoeducation around what they're experiencing, and helping patients realize that they're not alone, that other pregnant persons and birthing persons experience similar challenges during this time, and there are resources available to help. So speaking of resources, when we were first rolling out screening in our obstetrics and gynecology department at University of Iowa, where I was as a grad student at the time, one of the things that was the most anxiety provoking for our providers was knowing what to do if there was a positive screen, particularly for more severe mental health symptoms or challenges, and especially for suicidal ideation. And that feeling of concern over being powerless to help your patient make it to the mental health resource, or not knowing how to make an effective, warm referral, was something that came up again and again as a barrier to screening. So that's an area we really want to lean in and support you all on. So important to be sure that not only offer the resources, referrals to our patients for mental health treatment, but also that they're actually connecting with those referrals. So that labor and delivery, other times that we're checking in around physical health, there's so much going on for our patients. They're also understandably and importantly very focused on baby's well-being and health, and often have a number of follow-up appointments that they need to manage, take care of, prioritize baby's well-being. So helping facilitate getting our patients to those referrals that are for their own mental health and well-being is truly important. Thinking with your team around, do you have a protocol for making, and I would argue especially important, following up on referrals? So do you have a way to loop back to those patients you made a referral for and find out, were they able to connect with that clinic or that provider? Did that clinic or provider have a long wait list? Or were they able to take the client? Did they have an insurance disconnect with that clinic? Or did the clinic not accept Medicaid if you have a Medicaid patient? Are they not able to afford the service that the clinic is offering? What other challenges or difficulties are they experiencing with connecting with those referrals that you made? Something that my clinic and team runs into all the time is how quickly our referral lists are actually out of date, either because accepting new patient status has changed, or other providers, clinics are no longer offering certain services that we thought that they were, or taking different insurances, et cetera, payment models. So checking in somewhat regularly, I know it takes time, but checking in every once in a while to make sure that referral information is still up to date can be really useful, so they're not sending patients to other clinics that are actually not able to receive them. And then asking for tools from CPCQC, from PSI, and other resources for up-to-date referral lists is another way that you and your team can make sure that you actually have accurate and up-to-date referrals available for your patients. And here are some of those resources that we recommend. There is a PSI, Postpartum Support International Helpline. You or patients can call or text this line directly. There are postpartum support groups that are free, offered weekly online through PSI, that are led by a trained facilitator. There's a psychiatric consult line. I myself have called the line, and we have had limited access to a perinatal psychiatrist from time to time. There is a specific expert on perinatal psychosis who's available through PSI. So there's lots of resources that are there and free and available to you, your team, and your patients. And there are some additional resources that are listed here as well, including the resource map from CPCQC, which I think is so helpful to making sure you do have that up-to-date referral list.
So I'll end here just with our takeaway points. First is that we recommend that you choose your PMAD screening tools, ideally the validated tools that are made for the perinatal population, and then educate your staff on how to systematically screen. Think about when you're going to do the screenings, who's going to do the screening, how you're going to document the screening, and then what are sort of a workflow mapping for what are you going to do for a positive screen. I recommend that you know your hospital's resources for both inpatient and outpatient mental health care consultations and referrals. And Tracy highlighted a few of the really great ones for us here. And then have your team actively work on building relationships with outpatient mental health care services in order to bridge that gap between the obstetric care providers and the mental health care services that are available in the community. Sometimes more resources are available than you realize once you start digging into kind of who's functioning and who's working in your community and who's available for your patients to see. On a personal note, I'll note here that I was surprised when I first became a midwife as a perinatal care provider that perinatal mood and anxiety disorders were much more common and had really devastating outcomes, even when compared to gestational diabetes, right? And gestational diabetes is something we screen almost every single pregnant mom for, and pregnant patients are very familiar with the diabetes screening protocol. They all remember the gross drink that they had to drink and going and getting their blood sampled, and they all get anxious about it, and everyone's familiar with that. And I wonder, why it is that depression and anxiety screening tools aren't as familiar to perinatal patients as gestational diabetes. And so I encourage you to take it just as seriously as we do some of those more medical concerns. And I'll end here. This was a recently published White House blueprint for addressing maternal health crisis on the next slide. There's a really powerful statement that they included in this blueprint that I kind of wanted to send you off with. And in it, they said, untreated behavioral health conditions not only impact an individual health and quality of life, but they can affect the well-being of the baby and the family. They are the leading underlying cause of pregnancy-associated deaths, including suicides and drug overdoses and poisonings. Such deaths could be prevented by improved access to care and appropriate screenings in the prenatal and postpartum periods. And the very last slide here we'll leave you with is just a very basic workflow that CPCQC has created for maternal mental health care screenings. This could easily be customized for your website and to the specific tools that you're using. If you want help with customizing these tools, we are available. We would be happy to schedule a one-on-one with you to customize a specific workflow tool for maternal mental health care screenings at your site. So please reach out for us. And I think that's where we end. Thank you.
Thank you both so much. That was a phenomenal presentation. We have a few minutes just to talk about any questions you might have for Amber or Dr. Vozar, and you can put them in the chat or unmute yourself, and I'd be happy to help facilitate that.
I'll also say, please, if you are doing ACEs or social determinants of health screenings at your site, let us know if you're doing it and what tools that you're using.
Well, if no one has any questions, I would just want to give a warm thank you to both Dr. Vozar and Amber for presenting today. And it was great seeing you both. If you have any questions for either of them, I'm happy to connect you after the call. But for now, we will move on to 2 hospital presentations. We're going to first start out with St. James Hospital. And they can take it away. Do you have a PowerPoint that you would like me to share, or you'd like to screen share for yourself?
Well, I have a PowerPoint, but I'm honestly not sure how to share it because we moved to Microsoft from Google, so we're in this transition phase. So
yeah, so at the bottom of the
it.
screen, you should see a green up arrow, and then you can share your screen. And if that doesn't work, you can do it. Oh, it looks like it's going to work. Oh, there's me. Perfect.
Can you see it?
Yep.
I can't see you anymore, so I have no idea.
Yes, I can see you.
Okay. Well, not me, but you can see the presentation.
Yes.
Okay. Oh boy. Okay. So anyway, I'm Debbie. I'm from St. James in Butte, Montana, and our tested change is we started collecting the substance. Oh, I didn't mean to put that. We started collecting the substance use data, and when we started collecting that data, people were forgetting to do it. It wasn't getting completed on everybody. So then we decided that we needed to put a new process in place. So we've implemented a new process where we are now attaching the CPCQC substance use data collection form to the admission chart. And then if the patient screens positive for substance use on admission, the nurse is completing as much of that form as possible. She's returning it to the patient's chart, and then the discharge nurse is completing that prior to discharge. And then we also have a basket that she places the form in, so that I have a nurse who now is going to go back in TEDCAP to ensure that the information has been entered by the discharge nurse. I think one success is we do have good staff engagement from our staff regarding collecting this data. I think the problem is we have a lot of per diem people, and so hardwiring this and getting everyone to follow through, especially when we are busy, has created a lot of, I would say, issues for us. Like, it'll get started where half of it will be collected, but then after they deliver, it doesn't get collected, or it doesn't get entered into REDCap. So we've had some issues there. And then, like I said, our challenges are getting all the staff to follow the same process. We're seeing issues with our per diem staff, and remembering to complete the form prior to discharge and enter into REDCap. So we feel like if we keep all the forms and we have someone go back and check to make sure they've been entered, that we will fix that stopgap. That's all I have.
Great. Thank you so much for sharing, Debbie. Does anyone have any questions for Debbie or the St. James Hospital team? You're welcome again to put it in the chat or come off mute. If not, we can move over to Brooke with UC Health Highlands Ranch. And Brooke, I'm not sure if you have a PowerPoint or not, but you're welcome to share your screen.
I do not.
Okay, that's
I
fine.
don't have a PowerPoint. Well, the test of change that we are working on right now is I did print out those Audit C+2 tool that you gave to us and added that little personalized why we're asking the questions that you said you got from St. PSL, maybe?
Yes.
That's right. So just saying that we screen everyone for this and that we want to, we look at this as part of your medical treatment and that we want to be able to treat people to not, you know, look at it as a punitive thing if you're screening positive. And mainly one of the reasons for deciding to try that was we do not have very many patients who have screened positive at Highlands Ranch Hospital. And wondering if it might just be the way nurses are asking the questions and things like that. I am planning to put together some expert training for the staff, as well as other trainings that they can choose to do. But in the meantime, just seeing if we might be able to get more positive screens, finding people who are screening positive by letting them fill out the tool themselves. And I also found when we were submitting our July data that there were about 30 patients in the 3-month period that were not screened. There was no information entered. So maybe that we would have a higher percentage if everyone, sometimes people don't feel comfortable asking the questions, especially when other people are around, and then it gets missed and not put in later. So being able to give the patient the paper form and then entering it in. We've been doing that every day at Change of Shift. It's been being passed on that we're doing this with an example of the sheet, and we have that right up front with the text to put it on the clipboard for all the admissions to be able to get that screening tool completed. And then right now, it seems like we've had good support from the staff, feeling that this would be a good change to try and see how it works if we get more data, more patients screened, and if we are able to find more people that do respond yes, just by being able to read the questions and fill it out rather than having to be asked maybe in a more negative light by the staff. And that's our biggest thing that we're working on right now, but I'm excited to implement some of the things that were talked about today and more of the perinatal mental health things that we discussed. There was a lot of great information.
Great, Brooke, that's awesome to hear. I'm so excited that you're doing a small test of change, and that one from PSL is so great. If anyone else would like to use that one, it's in the team resources folder. It's a little like kind of snippet of paper that you can staple to the top of your screening tools, and it just gives kind of what you would say verbally, but it just kind of serves as a reminder if like the nurse that's handing them out forgets to do it, or just as a reminder to the patient if it gets buried under a bunch of stuff, what this tool is, why it's important. And so if you want to try that test of change as well, that's in the team resources folder.
It's nice that it's like short, sweet, to the point, and very, you know, easy for a patient to understand why we're screening.
Great. Does anyone have any questions for Brooke for the Highlands Ranch team? not, I just have a few quick reminders. Again, data is due tomorrow, July 15th. And so you can submit that in REDCap. If you have any questions or concerns, feel free to reach out to us, and you can email us at info@cpcqc.org. We're happy to meet one-on-one with you. We do have time available tomorrow. So if you need any assistance with REDCap, we're happy to provide that. Second, if you haven't submitted your June qualitative data, please do so at your earliest convenience. As a reminder, that's submitted through SurveyMonkey. That should be a brief little tool to use to kind of see where you are, see what tests of change you're doing, and if we at CPCQC can help you in any way. And then lastly, today we have continuing educations provided by Health One, and we're extremely thankful that they are able to provide those today. If you are a registered nurse who attended today, feel free to fill out this evaluation survey that I'm putting in the chat. It requires you to put in your name, email, Colorado nursing, what is it called, number, as well as a brief evaluation of today's educational requirements. And so if you do that, then we will provide you with CEs within 10 days. I'm also going to secondarily launch a poll for you all. That's just our evaluation survey at CPCQC. So if you could do that, we would be incredibly grateful for that. I'm launching that now via Zoom. And just finally, we're so glad that you all could make it today. We can end a little bit early, but please do fill out those evaluation polls. That would be really helpful for us. And we look forward to seeing you at our August coaching call.